I'm going to be talking to you about practical approaches to public health. So the first thing to start with is what we will not discuss. We are not going to talk about public health systems and architecture. We are not going to talk about manpower or resources or governance frameworks and policy. I think in order to understand what our approaches to public health can be for interventions in public health or improvements in public health, it's nice to have a breakdown of what we are trying to address. And for that, it's useful to think about the CDC's guidance to essential public health services that was published in 2020. Very helpfully, equity is at the center, and the areas are divided into assurance, assessment, and policy development. As I said, no policy development discussion, but we will talk about some aspects of assurance and my favorite topic, assessment. So in the context of infectious diseases, and to some extent vaccines, I'd like to talk a little bit about assessment and assurance, and within assessment, really look at signal detection and at monitoring. And in assurance, think about improvements, innovations, evaluations, measurement of impact, and how access can be assured. Now, if we look at signal detection, we have experience of signal detection. John Snow did a lot of that. But in infectious diseases, we continue to measure cases and track patterns. And this is important. It's critically important for us to be able to identify whether something is going on in a community or not. But I think one thing that people tend to forget about is establishing clinical case definitions and the importance of those to remain the same even if you are trying to measure things in different regions. If your definitions are not aligned, you're actually not measuring the same thing at all. Then you need laboratory capacity, and here again, standardization across labs is critical. When you use different assay methods, again, you're not measuring the same thing. And if we are to talk about signal detection for action, then timeliness and the ability to deliver interventions really does matter. Responses ultimately are local, and if you can't have feedback from the signal detection to those local responses, you haven't got a public health response. But now we have new tools that can augment our ability to detect signals, whether it is mobility data from our phones, which there are multiple machine learning and AI approaches using now. A number of tools were developed with variable levels of action. Your Trace Together app is a remarkable success. But when you are looking for signal, there are many ways of doing this. Finding where people congregate is one way. The other is to sit in hospitals and look at hospital data and how that can be used to identify clusters of cases. The one thing that matters is to remember that both old and new methods need to work in concert to identify these signals. Coming to monitoring, again, very helpfully, the WHO has a global reference list of 100 core indicators that allow us to think about measuring things over time. And looking at trajectories is one way that we have used very effectively to see how health systems are performing. We are all familiar with indicators like the under 5 mortality rate, the infant mortality rate, or immunization coverage over time. And this tells us a lot both about health systems and about the potential preparedness of those health systems to handle emergencies. If you can get your monitoring right, your monitoring is honest and complete, then you have very powerful tools available to you to be able to support and promote public health. If you don't get them right, you can be in deep trouble. And here what I have is India's systems for looking at vaccine preventable diseases. There are multiple sources of data, and those sources of data do not measure the same thing. So whether you're at state level or at central level, the data that you might be looking at will definitely not be identical. I'll give you one example. This is diphtheria outbreaks that occurred in 2 parts of the country. And there was one set of surveillance that was done by the Integrated Disease Surveillance Program, and the other was done by the National Polio Program. Same time, same locations, different numbers. And that's really because the sources of information that were used by the 2 surveillance systems were different. One used only government sources, and the other one included both government and private sources of data. So moving from there, just to summarize, for assessments, we need new tools. They are important, and they will influence our ability to detect and to measure new and old threats. But correct measurement will rely on standardization and completeness of data generation, collection, and analysis. All too frequently, when we get shiny new tools, we forget about our basics, and we should not be doing that. Moving from there to assurance, there's a lot of emphasis on medtech, on innovations, on new technologies, ways of improving things, and these could be classified into products, processes, and systems for delivery. So for products, you could look at smaller ultrasound machines. Butterfly ultrasound is something that is being evaluated quite widely. You could be looking at heat-stable vaccines that could ensure access to very remote populations. You could look at processes like risk stratification algorithms that can be generated and utilized even on mobile phones used by primary health workers. You could look at delivery mechanisms, whether that is behavior change, and mechanisms to support that, or drones to physically deliver interventions. But I think the one thing when we think about improvement and innovation is we need to ensure what impact we are looking for. And an ability to evaluate impact is critical to anything that we do in changing health systems. Now, particularly in low and middle income countries, it has been the policy to follow the norms that are established by WHO. WHO says do this and we do that. It's kind of, in some ways, naming and shaming strategy. You've been identified to not perform, now be good, behave yourself, do the right thing, and we'll stop with that. It worked very effectively in many ways. But I think ultimately a strong public health system is one that it learns to act on its own data. And too frequently in LMICs, we don't have that. So I'll show you an example from my favorite bug, which is rotavirus. And these are data from Mexico. Now, rotavirus vaccines were evaluated, and you had data on the efficacy of the vaccines, but efficacy of vaccines usually looks at severe disease. It does not look at what is important for public health systems, which is mortality. And we were privileged to have people in Mexico who worked with the CDC and looked at all-cause diarrheal mortality in Mexico after the vaccine was introduced. And those data clearly demonstrated that in the very first year of vaccine introduction, you had reduced deaths in infants, and by the second year, you had reduced deaths in toddlers. And this was an impact that was maintained over time. Subsequently, there has been a lot of work looking at the impact of rotavirus vaccines. And one of the things that has come out that to me is the most interesting is the fact that vaccine effectiveness studies done in high-income and low-income countries show two different things. And one example of that is when you vaccinate malnourished children. Now, most of these studies are done in a test-negative design, so you have chicken and egg problems. But the fact remains that when you have malnourished children that are recruited into these studies, there is a significant difference in the performance of the vaccine in well-nourished children versus poorly nourished children. So impact estimation is critical to understand what our interventions do really for public health. This is the Human Development Index. We all know where the problems are because you can take practically any public health problem, layer it over this map, and it'll show you similar patterns. The problems in sub-Saharan Africa and in South Asia. Now, I think that brings home to us that for public health, what really, really, really matters is where you're born and into which stratum of society, because that is going to determine what happens to our health, what happens to our economic and our educational prospects. A small proportion move out despite these constraints. The bulk of our populations don't. So if we need to change things for people around the world, we are going to need to focus on this. The WHO established the triple billion targets, which ensure that access and equity are at the heart of public health. And the idea was to improve care and protection, and not just from pandemics, but it is something that includes what we are talking about today, which is really what are our approaches to protecting people through prevention of disease. The reality is something that everybody knows. We live in a very, very disadvantaged world, and what we have to be moving towards is equity, and equity requires different levels of support for populations that are differently positioned at this time. So practically, to end, what can we do? We need needs-driven innovation. We have examples of where this has been successful in terms of organizations, CEPI, FIND, DNDi, the Medicines for Malaria Ventures. There have been organizations that have started to make a difference. We need to focus on new tools that are intended to provide access and equity, and we need the right kinds of partnerships. Without all of these, we cannot possibly succeed. So in summary, supporting public health requires breaking down what needs to be done by whom, where, and how. And for infectious diseases in particular, we need innovation across domains, from products to delivery. We need to change the world, and I think where we are today, we can do it. Thank you.